This is Ashley Gerard, and I am recording my didactic physical exam. I'm going to begin my physical exam by assessing the skin of the upper extremities. I'm looking at the color of the skin, which is slightly pink. I'm looking at the temperature of the skin, which is warm. I'm looking for skin turgor to assess hydration status, and the patient appears to be well hydrated. I'm looking for the presence of any lesions, as well as looking at the texture of the skin, which is smooth and intact. I'll then move on to the skin of the lower extremities. I'm also looking at the color, which is slightly pink, the temperature, which is warm. I'm checking skin turgor for hydration status. Skin turgor is good. I'm also looking for the presence of any lesions, and the texture of the skin, which is smooth and unbroken. And with the lower extremities, I'm also looking for the presence of edema, which does not appear to be present, as well as any varicosities, which I'm not seeing, and the distribution of the hair, which appears to be evenly distributed on the lower extremities. I'll then move on to assessing the head, face, and scalp. I'll be looking at, first I'm looking at the size, shape, and symmetry of the head. Size of the head appears in proportion with the rest of the body. The shape is round and it is symmetrical. I'll then move on to the scalp, and I'm inspecting the scalp for any breakage or dandruff, lesions, which I'm not seeing. I'm inspecting and palpating the hair, which appears thick and soft and evenly distributed with no thinning or graying. I'll then move on to the palpating the head, face, and scalp. I'm feeling for any lesions, bulges, tenderness, swelling. I'll palpate the paranasal sinuses for tenderness, which does not appear to be present. I'll also palpate the temporomandibular joint. If you can move your jaw, looking for any abnormal movement, click, or crepitus, which is not present. I'm also assessing for the innervation of the trigeminal nerve, which is cranial nerve number 5. Which controls jaw clench, lateral movement, and sensation. I'm also assessing cranial nerve number 7, the facial nerve, by asking the patient to smile, frown, puff out the cheeks, and purse the lips. So I'll then move on to my assessment of the eyes, and I'll begin by assessing visual acuity. And there are 2 tests that are used for visual acuity. One is the Snellen eye chart, which is usually much larger than this. And this is used for distance acuity, and it's usually about 20 feet away from the patient. The other is the Rosenbaum test, which is much smaller, and it's held 12 to 14 inches away from the patient. And with both of these tests, the lowest line the patient is able to read without mistake determines the visual acuity. And then, of course, visual acuity, I don't know if I mentioned this, is innervated by the optic nerve, cranial nerve number 2. I'll then perform confrontation, and so I will face the patient and ask him to cover one eye, and I will cover my own eye on the opposite side. And I'm going to ask the patient to let me know when he sees the pin light in his peripheral vision.
No.
And we'll switch to the other side.
No.
Okay. And so then I will move on to assessing the cranial nerves that control movement of the eye, and that is cranial nerves 3, 4, and 6, oculomotor, trochlear, and abducens. And I will do that by testing the 6 cardinal positions of gaze. And so I will ask the patient to focus on the pin light and follow it with his gaze without moving his head. And the movement of the eye appears to be completely intact. I'll then look for the corneal light reflex, the corneal, which appears to be present. I will also perform the cover-uncover test, looking for any abnormal movement of the eye, which is not present. I'll then move on to inspecting the external structures of the eye. So first I'm looking at the eyebrows, and eyelashes. I'm looking at the palpebral fissure, assessing for any lid lag, which does not appear to be present. These structures are symmetrical and appear to be functioning normally. I'll then be looking at the actual structures of the eye, the lids, sclera, conjunctiva, the iris, pupil, the lacrimal apparatus, anterior chamber, and they all appear to be normal. I will also palpate the lacrimal sac for any tenderness or swelling. Excuse me. I'll also be looking at the pupillary response to light, and there should be both direct and consensual accommodation to light, which does appear to be present. Okay. I will then move on to utilizing the ophthalmoscope to more closely inspect the eye. When I do this, I'll be looking for a couple of things. First, I'll be looking at lens clarity and looking for the presence of the red reflex. The lens should be clear with no lesions or presence of any abnormal coloration. I'll also be looking at the optic disc for its size, shape, color, the presence of the physiologic cup and its margins. The optic disc should appear to be a yellow-red, and it should be rounded. I'll also be looking at the retinal vessels. Major vessels should be present in all 4 quadrants of the eye. There should be no crossing of these vessels more than 2 disc diameters from the optic disc. I'll also be looking at the retinal background for presence of any hemorrhages or exudate, and for its color. And so I'm able to identify the optic disc, which appears normal in color. I'm also able to see the macula and fovea centralis. Okay. And so now I will move on to my assessment of the ear. And I will start by inspecting the external structures of the ear, the meatus and auricle. I will then use the otoscope to inspect the ear canal. I'll be looking at the tympanic membrane, which is bluish in color and appears slightly rounded. I'll also be looking at the umbo malleus and pars tensa, which appear normal. Okay. I will next be performing the whisper test. I'm going to whisper 3 words in the patient's ear and ask him to repeat those for me.
Cake wallet 3.
Okay.
Blanket cup 7.
Okay. Hearing appears to be intact, and of course hearing is controlled by the acoustic nerve, cranial nerve number 8. And so next I'll perform the Weber test, and so I'm going to hold this tuning fork at the midline of the patient's head and time how long he can feel the vibration.
Okay.
Alright. I will then perform the Rhine test comparing air and bone conduction.
Okay. Okay.
Alright, and air conduction should be twice as long as bone conduction. So I will now move on to my assessment of the nose. And so I'm looking at the size, shape, symmetry of the nose. It does appear symmetrical. The size is in proportion to the rest of the face. I'm looking at the turbinates and nares. I'm going to assess for patency of each nostril, so if you could occlude each nostril and breathe through the other. Both nostrils appear patent. I'm also going to assess for the sense of smell, which is controlled by the olfactory nerve, cranial nerve number 1. Can you identify this?
Close.
Very good. Okay, so I'll now move on to assessing the mouth. And with the mouth, I'm looking at the gums, the teeth, I'm looking at the buccal mucosa, the base of the sublingual area. I'm looking for the presence of Wharton's and Stinson's ducts. I'm looking for a movement of the tongue. The swallowing is innervated by the hypoglossal nerve, as well as the vagus nerve. The vagus nerve also, you can close your mouth. The vagus nerve also innervates swallowing and the gag reflex, which we will not demonstrate. Tongue movement is also innervated by the glossopharyngeal nerve, cranial nerve number 12. So I'll move on to assessment of the neck, and I'm looking at the size and symmetry of the neck. I'm also going to test for range of motion of the neck. If you can move your head from side to side, here, and rotate. Okay, very good. I'm going to test the strength of the spinal accessory nerve by asking the patient to shrug his shoulders against resistance and move his head from side to side against resistance. Okay, very good. I'm going to palpate the cervical spinous processes as well as the paravertebral muscles. I'm going to inspect and palpate the trachea for its position and symmetry. It does appear symmetrical. I am then going to palpate the pre- and post-auricular nodes, the submental, sublingual, and submandibular nodes, as well as the anterior, deep, and posterior cervical chains, which all appear normal. Let's see. Oh, and now I'm going to palpate and auscultate the carotid artery and the thyroid. And so I want to palpate the carotid one side at a time. And I'm just going to listen for any if you could swallow for me. And I don't hear any bruits or any abnormal sounds. And so now I will move on to my assessment of the lungs. And so the first thing I'm going to do is assess the anterior and posterior thorax. And I'm looking for symmetry of the chest wall, respiratory pattern, shape, contour. The chest is slightly concave. I'm also looking at the diameter of the thorax versus the upper chest. The next thing I'm going to do is palpate the thorax for any bulges or masses. I'm going to assess for chest expansion while the patient breathes. I am then going to palpate for tactile thermitis by asking the patient to repeat 99 while I palpate the back of the thorax.
99, 99, 99, 99.
Okay, I am then going to percuss the posterior thorax, and resonance should be felt throughout. I am then going to palpate for diaphragmatic excursion. So I'm going to have the patient put his back to me. And I am going to begin by percussing above the lowest point of dullness on each side of the thorax. And I'm going to percuss until resonance becomes dullness. And I'm going to mark that spot. I'm then going to have the patient exhale completely, and I'm going to percuss up until dullness becomes resonance and mark that spot. I'm going to have the patient inhale as I percuss down. I'm going to do that on the other side as well.
Breathe out, or?
I don't do anything right now. So until resonance becomes dullness. And have the patient exhale completely. Okay, and then inhale. Okay, and I'm going to measure that, and it should be about 3 to 5 centimeters. Slightly longer in this patient because he is relatively fit. Okay, and then the next thing I'm going to do is auscultate the posterior and anterior thorax. Okay. Okay. And what I'm going to do right now is pan the camera around the room to ensure that no study aids have been used.
I think you zoomed it in.
Okay. So the next thing I'm going to do is move on to my cardiovascular assessment. And I'm going to assess the patient. First, I'm going to visually assess the chest for any heaves, lifts, or thrusts. And I'm going to do that both while the patient is sitting and while the patient is reclined at 30 degrees. So if you get that.
Oh, okay.
Okay. And I'm not seeing any of that. Have the patient sit up again. And so I'm now going to palpate the chest for the point of maximal impact. And so I'm going to start at the right midclavicular line at the second intercostal space, and then move to the other side of the second intercostal space at the midclavicular line, and down to the third and the fourth, and then over to the fifth. And I feel a slight thrusting here, which is normal because this is the point of maximal impact. I am then going to auscultate the cardiac sounds. And then I'm going to start at the aortic area. It's this second intercostal space on the right. And here, S2 should be slightly louder than S1. It's a normal finding. I'll move over to the pulmonic area. And S2 can be heard more clearly than S1. I'll then move on to Erb's point at the third intercostal space. Here, S1 and S2 are roughly equal. And then I'll move on to the tricuspid or mitral area. And here S1 is slightly louder than S2, and finally to the aortic area. And here S1 can be heard much more clearly than S2. Okay. I'll now move on to my abdominal assessment. And I'll ask the patient to